So welcome, everybody. Lynn has asked me to introduce Ian, who's a friend and colleague who we managed to entice down from Leicester 10 years ago, was it? Just about 10 years ago. So Ian is a respiratory physician and has really changed the face of asthma in many ways. Those of you who can remember what an eosinophil is, Ian sort of put these on the map as a sort of aspect of asthma that can be attacked, and has helped introduce new treatments to asthma and made a big difference, particularly to refractory asthma sometimes, and has got a very difficult to treat asthma clinic, which he has huge numbers of people coming to. And so without much further ado, other than saying that Ian wants me to mention his golf handicap, but of course didn't tell me what it was. So I hand over to Ian and welcome.
Going up. Is that better? Yeah. Yes. Well, thank you very much, Chris, for those kind words of introduction, and thank you for enticing me to Oxford. It's been a really interesting journey. But what I'm going to tell you about is really, I suppose, a lifelong story, and this has been what's kept me preoccupied for the last 20 to 30 years. And it's really been a fascinating story to be part of. And maybe it's not fully over yet. But when I was editor of Thorax, we published a paper in 2015 that said asthma treatment really hasn't moved on from the blue inhaler, the brown inhaler, trying to persuade people to stop smoking and staring menacingly at the pet cat. And really, that's a very valid criticism of the progress during my time as a chest physician interested in asthma. And if you look at new drug discovery in various fields of medicine, respiratory medicine is bottom of the league table. Like my football team, Leicester City, at the time, we are bottom of the league table. And a particular issue in respiratory medicine is that drugs are failing late. So at phase 2B and phase 3, this is the phase in new drug discovery where big dollars need to be spent, hundreds of millions of pounds. And a failure at phase 3 is an utter disaster for the pharmaceutical industry. And the pharma industry in airways disease is very heavily UK dominated. So 80% of all asthma treatments are UK manufactured. So it's a particular issue for UK PLC. And patients are not doing well. This is slightly out of date data showing that on the top, the spending on asthma treatment goes up roughly threefold every 10 years. But during the last 10 years, and maybe 15 years, there's been no improvement in key outcomes. And you show on the bottom here, hospitalization rates by age from asthma over the same period as we've seen this big increase in spending on treatment. So we have this uncomfortable situation of deteriorating outcomes despite throwing more money at the problem. So I'm going to, I think, ask a few simple questions. You know, who needs new treatments? What are the main problems they would like us to solve? What's the best target? What mechanism should we be trying to target with these new treatments? And I'm going to talk particularly about biologic therapy in asthma, and the first biologic therapy, the first targeted biologic, anti-IL-5, mepolizumab. And what I think has been the key to the success of this drug and others has been a move from one size fits all, generic, poorly targeted treatment to a much more precision medicine approach where we target what I like to call treatable traits. These are mechanistic pathways that we can identify in people and that we can take out with treatments. We're not treating asthma or COPD, we're treating an asthma or a COPD, a subgroup of people that happen to possess that mechanistic pathway. So who needs new treatments? Well, it's very much patients who are at the top end of the asthma treatment escalator. So people at step 4 and step 5 who require a lot of treatment or who are uncontrolled despite taking a lot of treatment. And there's particular concern about the use of oral corticosteroids. So patients at step 5 of the asthma guidelines are usually on what I like to call everything but the kitchen sink. So every inhaler that's ever been invented, every oral medication, drugs like theophylline that cause sickness and gastroesophageal reflux disease, drugs that really have no prospect of helping. So this is therapeutic desperation. And the drugs we really don't want to use, but often have to, are regular oral corticosteroids. Because whilst they may well be useful clinically, they come with a severe price in terms of side effects. And a severe asthma doctor is often in the uncomfortable position of questioning whether it is the disease or the treatment for the disease that's the biggest issue. And what we did in the severe asthma clinic was manage an orderly decline and watch our patients slowly fall apart. And many of the problems that they acquired were iatrogenic. If we ask the patient what are the biggest problems that they worry most about exacerbations of their airways disease. These are episodes of asthma which don't respond to their rescue bronchodilators and that require emergency treatment. So they're inconvenient for the patient. They would like fewer symptoms, but symptoms are ranked rather lower than exacerbations, and they would like to be taking less treatment. So quite big ask. And of course, exacerbations are the most serious manifestation of asthma, and they still kill 1,500 people a year in the UK, and we've seen no fall in asthma death rates in the last 15 years. This actress, many of you will remember from 4 Weddings and a Funeral, her first experience of an asthma attack resulted in death, age 33, and her airway would have looked very like the airway shown on the left. The lumen full of a hard, sticky mucus plug, making it very difficult to get air into the person's lungs. And these exacerbations are what cost the most money. So costs of asthma increase exponentially as we move from treatment step 1 to treatment step 5, not unexpectedly. But what is very striking is the costs are particularly large in a patient that's had an asthma attack in the last year. So not only do clinicians worry about asthma attacks, the most serious manifestation of the disease, but those that pay for healthcare would also worry about asthma attacks. And the second big problem is the burden associated with oral corticosteroids. And many of our patients with severe asthma end up needing frequent courses or regular oral corticosteroids. And I don't need to tell you about the side effects, which are dose related, treatment duration related, and occur at the sort of doses of prednisolone that we need to use in asthma, which is in the 10 to 15 milligram a day range. And these side effects themselves cost a significant amount of money. To give you an example, this is a patient of mine, Vicky, who was one of those patients that sticks in your mind because she had terrible problems. And this is a very good example of a life lost to asthma. And it's a young life. She's 28. She's got 3 children under the age of 5. She has fairly typical adult onset disease with initial upper airway symptoms, nasal polyps, persistent rhinosinusitis, followed by lower airway symptoms, which right from the start were intractable and difficult to treat. She was exacerbation prone and had had 1 asthma attack that nearly killed her, requiring monitoring on ITU. Good evidence of airflow limitation, no question about the diagnosis. She's on everything but the kitchen sink, including prednisolone, 20 milligrams a day, and perhaps as a result of that, has gained a huge amount of weight, has become depressed, sleep disturbance, unable to work, and her husband's just left her. So the whole thing's very difficult. And this is a very common story in the severe asthma clinic, and it can be very difficult to unpick and find out what's really driving all of this. So eosinophilic airway inflammation as a treatment target. Might targeting that be a helpful thing to do for Vicky and patients like her? Well, we certainly thought so 20 years ago. Bronchoscopy studies had shown very clearly that most patients with asthma had pathological evidence of eosinophilic airway inflammation. We know these cells are highly toxic to the airway epithelium and change the composition of airway mucus, making it hard and sticky and particularly likely to plug airways. This is probably a immunological mechanisms that's involved in removal of worms from the airway lumen. That's what it's there for, but it's been activated inappropriately. And we know that when you worsen eosinophilic airway inflammation, for example, by giving an allergen challenge, or when you make it better by using inhaled steroids, asthma changes in parallel ways. So this looked like a key treatable trait for us to target. So the paradigm I had in my mind when I started working in asthma was that eosinophilic airway inflammation drives the abnormality of airway function that we see in asthma, which in turn drives symptoms and asthma attacks. And so the solution to asthma was to treat eosinophilic airway inflammation. It was a simple matter. At the same time as these bronchoscopies were being done, mainly in the UK, in Southampton and London, a group working in Mill Hill in the MRC Centre in London, led by the Australian Colin Sanderson, had identified what they called eosinophil differentiation factor and is now called IL-5. This murine cytokine clearly activated eosinophils. It caused them to grow, and its effects were highly specific for eosinophils. So IL-5 looked like it was a key cytokine involved in the growth and the activation of these toxic cells. And if you have a protein, it's relatively easy to block it using a monoclonal antibody. And it wasn't long after Colin Sanderson and Ankel Lopez described IL-5, we had a monoclonal antibody that blocked IL-5, mepolizumab. So let's get this into the clinic quick. And when we did, well, firstly, it works really well at reducing eosinophilic airway inflammation. At the top left, you can see the induced sputum eosinophil count. So this is the number of eosinophils in somebody's sputum before and for a month after one injection of mepolizumab. And there's no doubt it takes away this process completely. The problem was patients didn't get any better. At the bottom, you can see an assessment of airway responsiveness, a histamine challenge. So broadly speaking, the more severe your asthma it is the easier it is to make you wheezy with histamine. And mepolizumab, despite taking out eosinophilic airway inflammation, had no effect on histamine airway responsiveness. And in a subsequent reasonably big clinical trial shown on the right, 2 doses of mepolizumab given over 20 weeks had no real effect on morning peak expiratory flow or on symptoms in a group of patients with moderate to severe asthma. So this was a huge, huge disappointment. Remember, bottom of the league table, drugs failing at a late stage. This was another failure, very depressing at the time. Now, I happened to be working in Canada right when that, I remember being told that mepolizumab had failed in a pub in Canada. And at the time, I was working for a remarkable Englishman who's pictured on the right of the signpost, Freddie Hargreave, who had trained, I think, 70 professors of respiratory medicine in his time. He's a very modest, quiet Englishman, and he was obsessed with measurement in medicine. And he used to say to his clinical fellows on the first day, he used to give them the Lord Kelvin quote, you know, if you can't measure something, you can't talk about it. So focus on measurement. And at the time I was working in Canada, he had developed a technique for measuring airway inflammation by counting cells in sputum, doing a full blood count of sputum. And what we found was this was really quite an effective way of identifying the two major patterns of airway inflammation, eosinophilic airway inflammation and neutrophilic airway inflammation. And it really worked. And for the first time, we could measure airway inflammation in everyone because it was a non-invasive technique. So when I got back to Leicester as a consultant, I wrote a one-page ethics application, and 2 weeks later, the chairman of the ethics committee said, "That sounds fine, yeah, get on with it." I have no doubt this would not be possible now, but it was then. And we started measuring airway inflammation in every patient we saw in the clinic, asthma and COPD. And what we found was remarkable, exciting, and widely disbelieved, because it was, after all, Leicester. Only a proportion of people with asthma had eosinophilic airway inflammation, roughly a half. Secondly, it was quite common in the COPD clinic to see eosinophilic airway inflammation. So the label patients had didn't seem to identify this process in any useful way, but it was clearly very unusual in normal people. Second strong conclusion we made was when this process was present, the patients did well with steroids. And this is Newton's first law of airways disease. If there are eosinophils, the patient will respond to steroid. And you can see that in asthma and in COPD. It doesn't really matter what the label. So it looked like this was a useful measurement to make because it allowed you to predict a treatment response. We started to get this sort of conundrum in our clinic. These are two patients with severe asthma. The patient on the left, if you look at their diary card, has got disastrous asthma with terrible peak flows. They're using a lot of Ventolin, and they're reporting a hell of a lot of symptoms during the day and at night, but their sputum is completely clear of eosinophils. In contrast, the patient on the right, who has what you would consider to be well-controlled asthma with few symptoms, normal lung function, not using much Ventolin, has sputum that's full of eosinophils. What seemed to link to the process eosinophilic airway inflammation was the risk of asthma attacks. The patient on the left had never had a serious asthma attack. The patient on the right had nearly died twice of asthma, but didn't have much of a symptom problem. So the question arose, which of these patients should get more steroid treatment? The guidelines would say the patient on the left, whereas the measurement that we made suggests the patient on the right should be getting more steroids. So this became a key question and a key study. And we did a very nice trial where we took a group of 60 patients with severe asthma, randomized them to traditional symptom-guided management, shown in blue, and management that was guided by the sputum, shown in red. So if you were sputum management, you would have treated the guy on the right with more steroids. But if you were guideline-based management, it would have been the person on the left that would have got more steroids. And what we saw was, firstly, sputum-guided management achieved better control of eosinophilic airway inflammation. You can see the sputum eosinophil count over the year of the study was lower, very significantly lower, and that's what you would expect. We were targeting it and treating it. But there was no improvement in symptoms or in lung function. What we saw was a massive reduction in the risk of asthma attacks. So this was really interesting. This suggested that asthma attacks and symptoms are dissociated and that different mechanisms drive the two problems. This is a game changer. This was a game changer for us. And we needed a new model. So the model I showed you a little earlier clearly was wrong. What we have is two relatively independent treatable traits that are driving different problems. So we have eosinophilic airway inflammation driving exacerbations. We have an abnormality of airway function, which is probably linked more to symptoms. Now, this model predicts that if you have a drug that reduces eosinophilic airway inflammation very specifically, as mepolizumab did, it worked really well. It isn't going to work in people who have that problem. It's going to work in people that have eosinophilic airway inflammation, and the benefits are going to be on asthma attacks. So a beautiful way of testing this model, and this is what we do in science, we build models and then we test them, and we keep the model if it keeps working, and eventually it fails and we need a new model. But the best test of this model was to look to see what happened when we gave mepolizumab to people with eosinophilic airway inflammation. And we did a single center study funded by GSK, where we treated 60 patients, again, roughly the same patients as I showed you before, with severe asthma who had sputum evidence of eosinophilic airway inflammation. So they looked like the patient on the right, not the patient on the left. They were on everything but the kitchen sink, and they'd had 2 asthma attacks or more in the last year. And the primary outcome of this study was severe asthma attacks. And what we found was that mepolizumab on the left, it reduced the blood eosinophil count very markedly. It reduced the sputum eosinophil count very significantly, but it had no effect on airway function or on symptoms, maybe a small effect on symptoms. The big impact of treatment was to reduce asthma attacks, and it did so very convincingly in this study. So this was beautiful validation, I think, of the model I showed you, the new model. And it implied that this treatment did have a future, but only in people that had the treatable trait, eosinophilic airway inflammation. Now, at this point, GSK took some interest in their asset, which had been sitting in a freezer for 10 years, but they weren't convinced that this was a treatment. Firstly, no one was doing induced sputum measurements to identify eosinophilic airway inflammation. Secondly, the dose of mepolizumab we used, 750 milligrams IV, was about 5 times more than the dose that they wanted to use to make money. So the numbers guys said, we can't make money at that dose. And thirdly, asthma attacks were not seen as a reliable, valid outcome measure in clinical trials at the time. Lung function was the outcome measure we did. And one of the very high guys at Glaxo said, it encapsulated by saying, we're not a company about treating some asthma. We want treatments for everyone with asthma. So it did take some time to persuade GSK to follow this observation up, but they did eventually. And I pay credit to Steve Yancey, a very, very visionary American drug developer. And they did this phase 2B study. This is a 40 million pound study, 10 times as many patients as we studied in the proof of concept, and looked at 3 doses of mepolizumab, 75, which would definitely be profitable, 250, which is possibly profitable, and 750, which definitely isn't profitable, and looked at different criteria for eosinophilic airway inflammation. And one criteria was a raised blood eosinophil count. And this study beautifully replicated the proof of concept study. You can see on the top right, the effect on asthma attacks was almost identical to what we'd seen. And really interestingly and unexpectedly, the lower dose of mepolizumab was as effective as the higher dose. So this is now profitable. GSK really did start getting interested at this stage. And an interesting aside was that the drug effects on blood eosinophils, shown at the bottom left, and sputum eosinophils seem to be different. There was a clear dose-related effect on sputum eosinophils, but the clinical benefits seem to relate more closely to the effect on blood eosinophils and sputum eosinophils. And that was a very unexpected and interesting observation. But the fact that we had a biomarker, blood eosinophils, that everyone could measure, made this a very attractive and interesting finding. And in fact, it turned out that the blood eosinophils were an excellent predictor of response to mepolizumab. They were better than the sputum eosinophils, which was disappointing for me as a sputum guy. And they were certainly much better than tests that we traditionally measure in the asthma clinic, such as bronchodilator responsive airflow obstruction and allergy, which were not predictive of response to this drug at all. This is the relationship between the blood eosinophil count and the efficacy of treatment. And you can see the efficacy becomes apparent at a relatively low blood eosinophil count of 150 or 0.15 and gets progressively greater thereafter. The 75 milligram IV could be given by subcutaneous injection, which again was a very attractive undertaking because giving intravenous injections is a pain, but patients can give their own subcutaneous injections. And the Glaxo were able to show that 75 milligrams IV was equivalent to 100 milligrams subcutaneously. And in the subsequent phase 3 study, they showed that subcutaneous and intravenous mepolizumab was equally effective. And one particular feature of the mepolizumab clinical trial program is every study, the efficacy gets a little bit greater because we're getting better at identifying the responsive population. And in fact, real world data is even more compelling. And what's clear is if you happen to have a high blood eosinophil count, more than 500 cells per microliter or 0.5 times 10 to the 9 per liter, you have an astonishing response to this treatment. 80% reduction in asthma attacks, 300 mil improvement in lung function, and a very marked 12-point improvement in St. George's. The biggest drug effect we'd ever seen on St. George's questionnaire was 2 points before this study. This is 12 points. So this treatment, if you've got a very high blood eosinophil count, will change your life. I mentioned earlier that one of the big problems our patients had is toxicity linked to oral corticosteroids. And we did a phase 3 study where we looked at whether patients on mepolizumab were able to withdraw their oral corticosteroids without losing control of their asthma. And the answer was yes, they can. And this has been the most clinically impactful effect of mepolizumab in clinical practice. So oral corticosteroid use has really vanished. And I no longer see, I haven't started a patient with severe asthma on regular oral corticosteroids for 5 years. And it used to be the commonest thing we did in the severe asthma clinic. And that's been amazing. And a feature of this immunological pathway, I think it's in many respects an immunological appendix, is that you can inhibit it without really any issues. So this is the safety information from all of the studies I've shown you, and there's really very little there that's not seen with placebo. The only side effect that is reported more commonly with active treatment than with placebo is injection site reactions, and they are generally mild. So it's interesting to see this from 2014, the asthma treatment market worth 23 billion by 2023, and that the main driver will be biologics. In fact, the asthma treatment market is worth 40 billion this year, and 1/3 of that is biologic treatments. And you can see all the different biologics along the bottom here that have really come in now. And we're now top of the league table of new drug discovery, like Leicester City were in 2016, not bottom of the table. Everything we touch turns to gold. The picture shows Pranab Halder, who was the first author of the proof of concept study in Leicester, with Steve Yancey, who is the Glaxo guy that really pushed this drug through, and it would not be available without that. I should point out that the main manufacturers of biologics for asthma are UK based, so Glaxo and AstraZeneca. So this is a great UK success story. So Vicky, I'm pleased to report, she managed to get into the phase 3 oral steroid sparing study. She had rip-roaring eosinophilic airway inflammation with a very high blood eosinophil count. And as you would expect, she had a terrific response to treatment. And in fact, all of her problems went away, indicating that eosinophilic airway inflammation was very much a dominant treatable trait, and all the other issues were secondary to this. And she had, I bumped into her in the corridor of the hospital. I didn't recognize her because she'd lost so much weight. And she stopped me and said, look, this is what mepolizumab's done for me. And it was really, really lovely. We've got simple tests of type 2 airway inflammation or eosinophilic airway inflammation. And much of my time in Oxford has been about trying to get these tests measured in primary care. Because they tell you something that you need to know. There are two tests that are really easy to measure: the blood eosinophil count and exhaled nitric oxide, or FeNO. Exhaled nitric oxide is a marker of IL-13 activity in the airway, which is one of the other cytokines involved in type 2 inflammation, whereas the blood eosinophil count, as you've seen, is a measure of IL-5. It is clear that if you've got type 2 airway inflammation, it's given up on me again. It's bad news. So it's associated with an increased risk of asthma attacks. It's associated with an increased rate of decline in lung function. And it's associated with what I like to call people remodeling, which Vicky showed very beautifully, weight gain, depression, osteoporosis, diabetes, the sort of problems that we link to oral corticosteroids. So it's bad news if you've got type 2 eosinophilic airway inflammation. Simon Couliard, a fellow I had during the COVID pandemic, who was unable to generate any new data himself because of the pandemic, did this beautiful bit of work developing a risk scale where we can predict your asthma attack risk based on two biomarkers, FeNO and blood eosinophils. They are like the airway cholesterol and blood pressure. Now, you all, men of a certain age particularly, whenever they go to the GP, get their blood pressure and cholesterol measured and are told they've got a 14% risk of having a heart attack in the next 10 years, and they need to take 5 tablets to reduce that risk to 8%. We don't do anything in airways disease, but we have very good predictive biomarkers. So if you have asthma, ask your GP what your FeNO and blood eosinophils are, because you should know that, because they indicate a process that will drive issues for you in the future that we can treat. And you'll see if you've got high FeNO and high blood eosinophil, you have a 4 times higher risk of having an asthma attack in the next year compared to low FeNO and low blood eosinophils. Why is this not being done in primary care? Good question. I don't know why. Why does your doctor not want to know that you're at 4 times increased risk of having an asthma attack? Why don't you deserve to know that you're at 4 times increased risk of having an asthma attack? And if you knew that, would you make better decisions about treatment than you do currently? And let's face it, a lot of patients make bad treatment decisions. I think the future with these biologics is to get in early. What we're doing is a bit like the rheumatologists when they first had biologics. They're treating people with really badly damaged joints that there's a limit to what can be achieved. And we're treating people that have got really badly damaged airways. And we need to get in earlier and prevent that happening. And that's very much where we're going with biologics. And a patient with type 2 high asthma probably needs to be started on biologics sooner rather than later. What we currently do, the everything but the kitchen sink, is not good. Look what happened to Vicky. It's just not a sustainable approach. So thank you very much. It's been a lovely and very interesting journey. We've learned a lot about severe asthma. New models of disease have been needed. New biomarkers have had to be discovered. But we have been able to get mepolizumab and other biologics over the line, and they're having a big impact in the clinic, particularly on asthma attack rates and on requirements for oral corticosteroids, which are two of the biggest problems our patients have. We've got a brilliant theragnostic biomarker. We have a test that tells us this treatment will be successful, which I think even the rheumatologists don't have that, and they're jealous when I talk about this, because we can predict very well who's going to respond well to treatment. We've got lots of new successful treatments coming for this form of asthma, and I think there's a new wave of precision medicine happening in airways disease. So thank you very much, and thank you to the team who do all the work and allow me to go around the world, taking credit for it in normal times.